I'm Eric Bricker, and I've been a psychotherapist for over 25 years. One thing I can tell you for certain is that no one makes it through life unscathed. At some point, many of us will rely on the trusted counsel of another person to help us navigate difficult times, or to reconcile a troubled past. Whether conventional or unconventional, professional or informal, there are a lot of different forms that helping relationships can take. This podcast is an exploration into what makes these relationships work. Who are the people that help us? How do they help us? What do people need help with? My hope is to uncover as much as I can about this very human phenomenon, and I hope that you'll join me. This is the Good Counsel Podcast. I'm Eric Bricker. This is the Good Counsel Podcast. Today I'm going to be talking about prolonged grief disorder, and it's a subject I'm excited to talk about because I have presented on this subject live in the past. I did a continuing education event for other therapists a couple of years ago, and there were a lot of people who didn't get to attend the event that day that tell me they wish they had, and that material is not available. It was never recorded. So in doing this and recording it today, I'm making it available for folks, and there will be a recorded version that will exist on the podcast that people could tune into. So I'm excited to put that material together and make it available for folks. This is something I've been looking to get around to doing for quite a while. And so today is the day that I'm going to sit down and make this happen. So let's talk a little bit about prolonged grief disorder itself. In March of 2022, we created a definition for the diagnosis of prolonged grief disorder and included that into the Diagnostic and Statistical Manual of Psychiatric Disorders, the revised 5th edition. And what's significant about that is that now, in a technical and clinical way, there was an accepted definition of a form of complicated grief that differentiated itself from what would have been considered normal grief. In addition to that, in the research literature, it is also known that substance use disorders are often complicated by the existence of unresolved grief, and that grief itself can be a provocative factor in driving the onset of a substance use disorder. So it kind of works both ways. There's a synergistic impact between grief and substance misuse. And by taking a look at the intersection between this prolonged grief disorder and substance misuse, it allows for greater research opportunities about comorbid substance misuse and prolonged grief, as well as being able to contribute to the concurrent treatment of both of these conditions, which is actually something I've done in my practice working with individuals who have substance use disorders and prolonged or complicated grief reactions and helping them resolve those two things concurrently. So in order to have an intelligent discussion about this topic of prolonged grief disorder, I think we first have to discuss grief itself. And the first place that I'm looking is at our culture, which I experience to be a death-denying culture. I think we are very uncomfortable in the West with the subject matter of death itself, and that contributes a lot to how we experience it. In his book, The Denial of Death, Ernest Becker posits the question, what does it mean to be a self-conscious animal? The idea is ludicrous, if not monstrous. It means to know that one is food for worms. So what he's saying there, in a very blunt way, is that as these self-conscious individuals, we are aware of ourselves as separate and apart from other members of our species. We are able to construct an idea of time going backwards, which is our past, and time going forward, which is our future. And we know that our life is finite and that at some point it ends, so that we have to live our life knowing that at some point our life will end. And that really itself is a very complex existential idea to contend with. And I think it creates a lot of psychological problems for people in all kinds of different ways, especially because we don't necessarily have an agreed upon means in our culture to manage this idea that ultimately we are all going to die. So To give you kind of like a historical reference to the idea of death in other cultures, when the Romans were still using sundials to tell time, they would inscribe these kind of existential passages or phrases as a decoration for the sundial. And they would often reflect the connection between mortality and the passing of time. Inscribed on the sundials would be quotes like, "One of these hours will be your last," or "Be mindful of a brief light," or "It's later than you think." So these different quotes kind of ascribe to the passage of time a connection to the idea of mortality. And I think that in these earlier societies, there was probably a greater awareness of acceptance of death because the mortality rates were much higher. People died younger. There was a lot of infant mortality. They didn't have treatments for diseases. You could essentially die from a common cold. They didn't have, the kind of medical care and hospital care. And certainly the life expectancy was not what it is today, where people are easily living into the 80s unless there are complications. The lifespan expectancy is much, much more than it was a few thousand years ago. So I think that has kind of put us out of touch in some ways with the inevitability and reality of our own mortality. So just to say, grief itself is a kind of complex matter because we already conceptually have difficulty with the idea of dying. So how do we conceptualize the grief process if we are already this uncomfortable with the idea of death itself? In 1969, Elizabeth Kubler-Ross published her best-selling book based on her research. It is called On Death and Dying. It was normed on the experiences of individuals who were in the end stages of terminal illness. So she was doing her research on these individuals who were in hospitals and dying of these terminal conditions. And this is where she came up with the 5 phases of grief that are probably the most repeated conceptualization of the grieving process that we all sort of accept as normal. The idea of denial, anger, bargaining, depression, and ultimately acceptance, and the idea that these phases could kind of come in any order. And this conceptualization was accepted as sort of what would be the normal grieving process, except for one thing, which I think is a pretty important matter that later critics of the theory would eventually bring. And that is that her subjects were individuals who were dying of terminal illness, right? So based on her research, these were kind of the universal experiences that these people had, where there would be periods of denial and periods of anger and moments of depression and then bargaining and then ultimately acceptance of their own mortality. But the question here is, well, is the experience of a terminally ill patient facing the inevitability of their own mortality, is that the same thing as the experience of a loved one who has just lost a beloved family member or friend? I think when you look at it from that perspective, it's really 2 different things. So the idea of these 5 phases of grief, as they're known to us, coming out of Elizabeth Kubler-Ross's research, I think they might be inappropriately applied to the general population, because that's not the population of research subjects that she was studying when she came up with these 5 phases of grief, right? She was talking to terminally ill individuals, and I think we could all agree that a terminally ill individual is not the same thing as a bereaved family member. And that's all I'm trying to say here. Elizabeth Kubler-Ross is a respected researcher. Her contributions to what we know about death and mortality are pretty legendary. She is largely credited with being a driving force in the hospice movement and for also all of this other pioneering work in increasing our understanding of near-death experiences and a whole bunch of other things. So she's a very important research figure. I just don't think that she ever intended her research to be misapplied this way. So it's not her fault. It's, in my mind, you take a death-denying culture, you provide them with some easy to conceptualize idea of what grief is. Oh, we've got these 5 phases and this is what everyone goes through when somebody dies. And then that becomes it. That becomes our normalization of this process. And we don't think to take it any further. We don't have a reason to. We have something that is acceptable and understood. Later on, there were other researchers who studied this subject matter, particularly with the advent of treating grief. So the idea is we're looking at grief and death more closely because we know that there is a phenomenon that takes place of suffering for loved ones that is not clearly understood and causes a great deal of struggle and suffering. And perhaps if we were to develop a better understanding of it, a different understanding of it, we can treat these conditions and help people find comfort and relief while they are suffering during these periods of loss. Among the most prolific and well-researched is a woman by the name of Catherine Shear. She is a professor of psychiatry at Columbia School of Social Work and Columbia College of Physicians and Surgeons, and she is the founding director of the Center for Prolonged Grief at Columbia University. And in her research, which is, like I said, she was a prolific researcher and published a lot of studies on the subject matter. So Catherine Shear concluded that grief doesn't really occur in stages like denial, bargaining, depression, and acceptance. She says it's not phasic at all. So that kind of dispels a lot of the ideologies that we had about grief in the first place. Catherine Shear's belief is that grief is really largely rooted in attachment and bonding. She conceptualized several attachment models. So I'm going to try to explain this briefly. So human connection and attachment is conceptualized through the bonding process. So this is how these attachments are developed. We have these mirror neurons that allow us to kind of get in sync with each other. So when you see a mom, the best way I can explain that is if you see a mom sort of looking into the eyes of the infant, and maybe the infant is crying and the mom is mimicking the expression of the infant, and the infant is looking into the eyes of the mother and maybe mimicking her expression. There's a connection that's happening there of the communication of empathy, that I understand you and I'm trying to be here with you and we're connecting. And there's actually a neurological mechanism for that through these mirror neurons in the eyes and through the sympathetic nervous system. And that's a whole long neurological explanation of the idea of attachment and bonding that I don't want to get into. But except to explain that it does exist, and that's an important part of the grief process, because what grief is, essentially, it's a form of severed attachment. That's just a different way of conceptualizing the idea of loss, is that we can look at it like a severed attachment and think about the profound emotional reactions that people have when an attachment is severed. If we're talking about prolonged grief, which is a grieving experience that extends beyond what is normal, then we have to have some idea of what normal grief actually is. And even though we as a society are prone to say, well, everybody grieves differently, I think that is true. But through a lot of research at New York University and Columbia University, and with people like Catherine Shear, they were able to identify these grief models, which basically represent the experience of the largest segment of society and what these larger groups of people are typically experiencing. So researchers like Catherine Shear and like some other researchers at the New York School of Psychiatry have developed these 4 grief models for what is considered normal grief, the trajectory, which in all 4 cases takes place from 1 to 3 years. And that's pretty much the normal experience of what people go through. So the first model shows stable low levels of grief symptoms over time, and that's between 26 and 45% of people. The next is moderate levels of grief, which is 30% to 33% of people. The next is higher levels of grief, which is 16% to 20% of people. And then 10% of people will experience what is considered delayed onset. And that is an experience of the grieving process that doesn't take place until some point, and it could be a significant amount of time after the actual loss is experienced. So the majority of individuals will move from the acute phase of grief, where the most suffering is happening, into integrated grief within 6 to 12 months. So the difference between acute grief and integrated grief is that acute grief are the more intense grief symptoms where our normal activities are disrupted because of the disturbance of the grief. And in most cases, that abates between 6 and 12 months post-loss. And we go from acute grief into integrated grief, which is I have resumed my normal activities of either being a parent or my work or my relationships or whatever else it is that is normal for me to do. I am still experiencing symptoms. I might still be experiencing, some degrees of suffering and disturbance related to grief, but there is an abatement of the severity of it, and I am moving into more of my normal levels of functioning. So in terms of what acute grief is a period of intense emotions characterized by a preoccupation with thoughts and memories of the deceased person that may result in reduced engagement in life and activities. So this is a period of grief where the experience of it is so severe that the person is having difficulty participating in their regular levels of functioning. Factors that influence how acute grief is experienced. There are cultural factors, what is appropriate for our culture and what has been modeled for an individual. The relationship factors, in terms of what our relationship to the deceased is, and circumstances surrounding the death of the individual. So that is all three of those factors: the cultural piece, the relationship to the deceased, and circumstances surrounding death, particularly if those circumstances were traumatic. All of these things are going to impact the manner in which grief is experienced. Integrated grief occurs in most cases following a period of acute grief. Again, typically, this would be happening between 6 and 12 months post-loss, that typically people would move from an acute phase of grief into an integrated grief. And this is characterized by the individual has adapted to the sense of loss, that the grief is more in the background, and that the individual can meaningfully re-engage in life without the deceased. So they're at a place of acceptance. So what is prolonged grief? What prolonged grief disorder is, it's a severe and persistent grief and mourning reaction. And this occurs in about 7 to 10% of bereaved individuals. They will experience the syndrome of grief that does not resolve itself naturally and persists for an indefinite period of time with varying degrees of incapacitation. So they're going to struggle. It's sort of like this extension of the acute phase of grief that goes far beyond the 6 to 12 months that a person would normally be expected to experience. And it's characterized by elevated and persistent emotional distress, maladaptive thoughts like guilt or blame, lots of avoidance, an inability to manage emotions, and a negative impact on health and social factors. So this is a really severe level of impairment that we're experiencing, going on longer than the acute phase of grief, where the person is not able to resume their regular level of functioning that they had pre-loss. And this is going on for a period longer than a year. So prolonged grief disorder symptoms, feelings of disbelief or inability to accept the loss, identity of disruption. Basically, I'm confused about my reality. There are perhaps avoidance of the reminders of the deceased, or the opposite, which is constantly seeking out or being preoccupied or being obsessed with thoughts of the deceased person. Rumination about the circumstances surrounding death. This is particularly true when there was a traumatic death, when someone dies in a hospital, or when someone dies suddenly, or when someone dies of a really traumatic or tragic cause. There's a lot of bitterness about the death. There's the experience of pain that the deceased has suffered, and hearing or seeing the deceased person, that all of that, the thinking about the person, seeing images of the person, hearing about it, all of it is very painful. And trouble trusting or caring about others. And all of these are these clinically significant impairment. This is highly pathologized and is a form of suffering. It really is a mental health issue. And I think that's really the shift in the characterization of prolonged grief disorder from the normal grieving process, is that there's actually a decline in functioning here. I think the difference between prolonged grief and regular grief is, one, the amount of time, but two, that prolonged grief disorder is really distinguished by being a mental health issue as opposed to just being an extension of what is a normal part of life, right? Losing people is a normal part of life, but prolonged grief disorder is actually pathological, right? Like our levels of functioning are impaired beyond what would be considered normal for the vast majority of individuals in society. And I know we kind of get into some difficulty. I think people can be very uncomfortable with the idea of normalizing grief or talking about grief in terms of what is normal. However, it's really about establishing a baseline based in research about what the vast majority of people experience. So it's not to say that you're abnormal for having a strong grief reaction, not to say that at all. It's just saying that the vast majority of people experience these acute and integrated phases of grief, or have transitioned from the acute phase of grief into the integrated phase of grief somewhere within a year period. And that if you're an outlier of that, that may be a sign that you are in need of some kind of help and assistance, because you're doing a great deal of suffering, and that there is treatment and help available. And that's the good part about it. I'm going to stray away from getting into the substance use disorder part of this, because what I've decided is I'm going to go ahead and separate these into two different lectures. So the first one will be this explanation of complicated grief itself, and the second half, or the second episode, will be the discussion of the intersection of substance use disorders and complicated grief. So I think that that's kind of room for two of these, rather than trying to condense this lengthy subject matter into one discussion. I know at the beginning of this, I said that this was going to be a discussion about prolonged grief disorder and substance use disorders, and it will. I'm just going to go ahead and divide that up into two pieces. There are certain complications that people experience in the prolonged grief process that sort of further complicate the issue and complicate the normal resolution of the grieving process. And these are things that are really opportunities in therapy. So when I'm trying to kind of work out or normalize my relationship with the individual who I have lost and try to reintegrate my relationship with that individual now that they're no longer here, and how I want to think about that relationship and how I want to think about them. So it's the idea of reconfiguring the internalized relationship. That's sort of one of the goals of grief therapy, and accepting the reality that the person is in fact gone and envisioning ways to move forward with a sense of purpose and meaning and for possibilities of happiness. These are the three big goals of grief therapy: accepting the reality that the person is gone, including all of the finality and the consequences of the loss; reconfiguring my internalized relationship with the deceased person and incorporating this into my reality; and envisioning ways to move forward with a sense of purpose and meaning and for the possibility of happiness. So even though this person is gone and it's very sad that they're no longer here, I am looking into my life as having a future without my lost loved one, and that future will have some degree of optimism or the possibility that there are still good things in my life yet to occur. So one of the complications in working with the grieving population is something that I call the halo effect. That in order to truly accept the loss and to be able to move forward with a more global and complete experience of what that relationship was, I have to be able to look at that lost loved one as they really were, as I really experienced them in my life. And there's this thing that I refer to as the halo effect, which is that oftentimes when someone has passed, we have a tendency to canonize them, basically turn them into a saint, because it is our custom not to speak ill of the dead or think ill of the dead. It can be incredibly guilt-provoking to have negative thoughts about loved ones who are passed. And here's the problem with that. If I am going to reconcile my relationship with this lost loved one, I have to be honest with myself about what the relationship was. And then you see this typically with people when their parents die, that there's often great difficulty in acknowledging the conflicted nature of some of the relationship issues or some of the unresolved conflicts. And so part of grief work is often resolving conflicts that we had with the lost loved one, or perhaps even difficulties that we have or feelings of abandonment that we may have about the fact that they left us here without them and that now we have to go forward in our life without them. So that is an important thing to consider, is kind of reconciling the relationship, and that in order to reconcile the relationship, we have to be honest with ourselves about what that relationship actually was. One of the elements of being able to move through these conflicted relationships is the capacity for forgiveness. So Robert Enright, the founder of the International Forgiveness Institute, he says that longitudinal studies suggest that people who forgive are less angry, neurotic, and enjoy better cardiovascular health. As of 2006, the Journal of Behavioral Cognitive Therapy says that there is no consensus for a psychological definition of forgiveness in research literature. And I don't think that has changed up to this point. So the paradox of this whole conflict is, on one hand, we're asked to forgive, but on the other hand, we're not really always clear about what it means to forgive. And that could be very confusing. So there are elements of forgiveness that I think are important to consider in terms of a pathway towards forgiveness, as far as giving us a little bit of a compass and direction into what forgiveness might provide for us. So there's a fundamental difference between what we call forgiveness and what we call condoning, which is that forgiving someone doesn't necessarily condone their actions. So if I was mistreated at a certain point by a parent or a loved one or someone that has passed, or they did something to me and that is unresolved, if I make the choice to forgive them, that's not the same thing as condoning what they do. It's just my choice to work toward not feeling bad about it. Another element that moves us in the direction of forgiveness is compassion for ourselves and for others. And by compassion, I'm talking about the recognition that they're suffering, that this person may have suffered, that I have suffered, that no one makes it through the developmental process unscathed, and that often how we show up in relationships is a manifestation of the suffering we've experienced. And to try to acknowledge that the person that we may be resentful of is or has been a living, breathing human being with having experienced all of the human experiences and may have had difficult times in their life. And that we can understand that they have a point of view and a perspective that may be very different from our own. And then there is what I call the exorcism metaphor, which is to think of forgiveness as basically exorcising a demon. And if you look at all of the anger and, what it means to be anger and what it means to hold on to resentment towards others, and how there are all of these, metaphorical quotes about it that, what is it that we say? That anger is the only poison that destroys the vessel that contains it. Or the famous quote by Buddha, which is that you will never be punished for your anger, but you will be punished by your anger. So the idea of anger being something that we hold inside of us that is like a poison, like a demon or a bad spirit, and that we are seeking to exorcise ourselves of this negativity by having compassion for the person that harmed us or by forgiving them. And that sometimes we have to look into these things, specifically when we are talking about the loss of an individual with whom we had a somewhat conflicted relationship. I also recommend a lot of journaling and letter writing. I think that these things are very powerful tools to use in therapy. I have my own formula for writing a grief letter, and I'll share it with you now. So it's all about trying to reconfigure our internalized relationship with these thoughts of the future. So we're trying to create a different type of relationship with our lost loved one by thinking about how we want to experience them going forward. So here are the 6 elements that I like to consider for constructing a letter to a deceased loved one. The first is to state our unfinished business is whatever the outstanding resentments or issues or problems in the relationship are. I want to write that down, whatever the unfinished piece is, whatever I might not have gotten to say before the person passed away, whatever conversation I wished I had had that I didn't get to have. I'm going to include all of that in this letter. Next is my commitment to work to resolve the unfinished business. So what I'm going to do here is I'm going to write down my intention about the work that I'm doing in my own life to resolve this unfinished business, and what I'm working on in this relationship to let go of whatever it is I might be holding on to. And third is, here's what I'd like you to know. Here's what I'd like to say to you that perhaps I didn't get a chance to tell you while you were alive. So I'm going to include this incomplete communications into this letter, and that's a very important element. And next is legacy. I am choosing to remember you as the person who did blank, the person who taught me something, the person who gave me something, the person who inspired me in some way. I'm choosing to remember you as this person. Number 5, I am grateful to you for whatever you might be thankful, whatever this person contributed to your life. You want to take a moment now to honor that and to state it on paper, to write it down, committed to that I am grateful to you for X. And lastly, I am committing to honor your memory by blank. So the idea is that I'm going to commit to honor your memory by doing certain things. And this will allow me to stay connected to you, because hopefully by honoring your memory, I am maintaining some relationship with the deceased person. So it allows me to stay connected to them in some ways. So I think that's going to do it for now for the conversation about prolonged grief. I think that isolating that to a single episode is probably a good idea. And the next one I'm going to do is going to be more of an explanation of the intersection of prolonged grief with substance use disorder. So I'm going to divide that up into two different pieces. Thank you so much for tuning in and checking this out. I really appreciate the support and interest. Obviously, this is a big part of my practice. I'm very passionate about these issues, so I like speaking about them. It's also a way of further educating myself and reminding myself and just really honing in on the work. So all of this is really great to me, and I appreciate that there are people out there that support these efforts and are willing to, listen and tune in to these lectures, these episodes. So thank you again. And please know that the next one will be substance use disorders and prolonged grief disorder and the intersection of those two things. Thank you.